Okay, cool. We're recording now. And share screen.
Okay.
Wait, can you see my screen?
Yeah. I can.
Oh, cool.
It says Rachel. I'm sorry. It says, oh, there it is. It's right there.
Ah, okay, perfect. Oh wait, you know what? I'm gonna change my last name to just the last initial, because otherwise the PsyD student gets truncated and then it looks like Rochelle Fernandez PsyD. And they were very particular about never misrepresent. Okay, there we go. Student. All right, okay. So I'm gonna replicate Dr. Bohart's lecture. He skipped through all of this. Okay, so what is transference-focused psychotherapy? So it was the first manualized, meaning you create a manual and you have like a set way to go through the process as an evidence-based method. So it was the first manualized psychodynamic treatment for borderline personality disorder. What is psychodynamic? So and I'm just trying to remember exactly what he said and just do that with you, okay, Erica?
Okay.
So the way what he said in class was psychodynamic is a view of a person as the psyche soma. You know, I don't know if you took object relations, but the psyche soma as in a constant and dynamic interrelation with itself. And because of that constant dynamic relation with itself, that's why psychodynamic. A view of the mind is constantly in flux with conflicts between opposing urges, and understanding these conflicts within the mind as underlying symptoms, meaning it's more from what's internally organically going on versus like say some external force oppressing you, etc. And I think that is the reason why possibly psychodynamic is not so much in favor these days, with the view being that, you know, it's situational. Things are situational and it's environmental, which, you know, is true to some degree, but then there's a balance. There's always a balance. And in the psychodynamic view, it's very much, you know, what's inside, what's going on in you, and how that's coming out of you in your interaction with the external world. So why bother working at this level? Right. So, and this, I mean, from a full-on psychodynamic perspective, it is in order to create to change the psychological substructure, because when you're working with personality disorders, not just borderline personality disorder, but any personality disorder, you're trying to work with the substructure layer of the personality. You're not just working with, like, say, you know, in CBT, you're working to change a certain behavior, or you know, certain things that are known cognitively. You're trying to change and heal personality substructures. And that's why psychodynamic is so important. To improve reflective functioning. He touched upon this quite a bit, where it was, so reflective functioning is where you are able to, like, take perspective sort of on what the interaction was and then reflect on it. And what happens in borderline personality disorders, or many personality disorders, but primarily in borderline personality disorder, where if the client is so wrapped up in that, like drama, and I don't mean that in a bad way, but like in the drama of the emotion and the pain and whatever is going on, then it's hard to kind of just take that step back and reflect. And so that's the reason why helping healing that substructure helps to improve the reflective functioning and to promote psychological integration. And this one actually, outside of Bohart's lecture, I listened to some of Dr. Kernberg's work, Otto Kernberg, and I set it up here so I can show them to you, or I can even send them to you, in separate links. But these videos by Dr. Kernberg were really, really good.
Okay.
Yeah, like straight from the horse's mouth, basically, because he talks about sort of like, okay, here, like narcissism as a defense against borderline. What he means by this is like a in terms of like the vulnerable child, right, that has not yet healed that vulnerability. If they're trying to act invulnerable and defense, they're trying to put up a defense that tends to present itself as narcissism. But really, when you like peel back the onion, it's like the same, it's like the two different sides of the same borderline coin, so to speak. Or not borderline coin, but the same sort of unhealed stuff and attachment trauma. Ultimately, in some sense, all roads lead to attachment in a way. So
yeah, that's true.
Yeah. So the characteristics of transference-focused psychotherapy, and I watched a few of Otto Kernberg's videos also about this, because I felt like it's best to know sort of from the person who created it. And it was fascinating because so the treatment is structured by making, first of all, a contract. It's very intensive. It is 2 sessions per week, and it's long-term, relatively speaking, given our like insurance restrictions and whatnot. It's a 1-year minimum. And the focus is on the here and now. And the reason for that focus in the here and now, and interestingly, I just learned this yesterday in one of my doctoral classes, where my professor said that sort of in many personality disorders, the problem, so to speak, is that it's almost like a person is like a bit too much in the here and now, which is interesting because it's like my professor was telling us something about like antisocial personality disorder, or like extreme psychopathy, etc. And he was saying how like a person will go ahead and kill someone. Why? Just because it had to be done in that moment. It's that in some ways it's like an extreme and I don't know much of neurobiology, so I'm caveating this, but it's like an extreme non-prefrontal cortex usage of like, oh, what are the consequences? How is this going to be? How am I going to feel? How is this? No, none of that. Just, so yeah. So there's that element. And because of that ability, in a way, really, a gift to be in the present moment, the focus of transference-focused psychotherapy is that in those 2 interactions, those 2, the 2 sessions per week interactions, the therapist and the client recreate this sort of dyad business, recreate the interpersonal situations that occur outside, and not as role play or anything, but because the moods and the affect is so labile, there will be this shift where a person will, go into, and this kind of comes more later in Dr. Bohart's slides, but where, where he talks about the object and the self and the object and how that's seen in a dyad view. So, so the reason for this immediate interaction is that when the therapist, when they notice that, oh, like you went from like subservient child, or like a different sort of mode or mood, to now you're attacking me because I'm all bad, right? They can like just hold that space in that moment and say, all right, what's going on here? Do you notice, do you notice that, and that this is something Bohart said on Monday. He said, the skill is not to tell the client, like, do you notice you're doing this right now? But to say, like, it feels to me that you're seeing me as a persecutor right now. Because then that builds that pause and that reflective functioning rather. So that's kind of what's going on. It's almost like an in vivo therapy for like an exposure and response prevention kind of thing, but it's almost in vivo like that. So that, hence the reason for the focus on the immediate interaction. Can be augmented with auxiliary. Yeah, in that he said about he spoke about like augmenting it with like DBT type classes. And correction to what I told you earlier about DBT having 3 modules, it has 4 modules. One of them is mindfulness, interpersonal effectiveness, distress tolerance, and emotional regulation. Yeah. So, and can include periodic contact with family. Yeah, I don't remember him saying much about that in class. Yeah. Who is TFP for? Patients with symptoms of depression, anxiety, difficulty with interpersonal relations. He didn't say much about this, except he did speak about the chronic maladaptive personality patterns. And then he went into it sort of more in this one. This is kind of where he went into quite a bit of detail. And here I took some notes actually, because, oh, wait, hold on. In the goal slide, he did say something about, no, he spoke about goals. I'm going to just say them because I wrote them here. He said basically, and it ties in with this one. Yeah, with the chronic maladaptive personality patterns. He said that there are 2 phases of the treatment. In phase 1, there's containment of self-destructive behaviors, cutting, etc., and other things too, like self-sabotage, whatever. Phase 2 is the core of the treatment, and it is the resolution of identity diffusion and a development of a coherent sense of self and others. So where you kind of stop viewing yourself in relation to how the dyad is playing out, and you can see yourself as good and bad, competent and incompetent, reliable and unreliable, brilliant and a little bit funky on some things. It's like, whatever, it's, and being able to see everybody else like that too. That it's not like, oh, you're my savior, and oh, you're my, I hate you kind of thing. Not that extreme kind of thing. And he goes into sort of the why that happens. And I think it's in one of the later slides, but let me go into this bit, because this was a fascinating slide for me. So in terms of personality, so yeah, introverted, extroverted, but look at it this way. So the neurotic personality organization high borderline personality organization, low borderline personality organization, psychotic level of personality organization. Now, what's important to note here is that this does not mean high borderline personality. It is how the high borderline personality organization schema works. And one interesting thing, which was a question I had asked him, was why, like, so I got confused in class. I don't know if you remember that bit, but when I was in class, I here in the neurotic personality disorder, it's not, see, I made the mistake myself. It's not neurotic personality, it's neurotic, the organization of a neurotic personality. There's obsessive compulsive, depressive, masochistic, on the internal, internalized type of things, and then the externalized type of things, the hysterical. And I think, these slides are kind of old, right? Because I think he said that they were like someone else's presented at some conference in some years back. So the interesting thing here is this: high means high functioning. Because when I read this, I got very confused because I thought avoidant, dependent, sadomasochistic, histrionic, narcissistic. And then if you look at low, it's paranoid, hypochondriacal, schizotypal, hypomanic, borderline personality disorder, malignant narcissism, antisocial, and then it goes to psychosis. And I'm thinking, whoa, like, isn't that like, if on a spectrum, wouldn't this be high? Like, as in high need for treatment, or that kind of, or high level of distress, etc. But then he clarified that understanding for me, which was great. And sorry, my brain just goes like a tape recorder, so I go like by what he said and what I remember like that. Did I make any notes on this bit? Okay, no, yeah, oh yeah, this was a good one. So he said that the defining psychological characteristics of borderline personality organization is that sense of identity diffusion, and that sense of that's when he started getting into that self versus other thing. This split and fragmented thing is super fascinating, because Melanie Klein talks a lot about it. I don't know if you've watched any of her stuff or read her stuff.
I don't know who she is.
No? Okay. She's, I think she came after Freud or something. Yeah, I'm pretty sure she was after Freud, but sort of in the 1930s, maybe 1930s to 1950s era. And she came up with this theory. There's a really comical video on YouTube about it that I'll send it to you later, but it's here, this one here. It's quite funny. You see this? You see how it's kind of like, oh, okay, and this one too, object relations. She, when I first read it, like, the mother in me got really pissed, because I was like, what the, I was quite annoyed by it. But then I have this tendency, if I don't like a theory, I like to read more about it to know why I don't like it, because like I delve into it all the more. So sorry about that noise. So when I first read it, what was it? It said something about like, oh, there's the good breast and the bad breast, and like the child. Yeah. So I was like, what? Like, what do you mean? Like, this is so much blame for us poor mothers. Like, what the hell? Like, I was pissed. But then I sat down and I read the book properly, and I was like, oh, wait, calm down, emotionally regulated myself, started reading more of her stuff. And I really actually enjoy her stuff. So this sense of identity, right, is created in early childhood when you're forming attachments with your primary caregiver. So think about it this way: your baby, you want milk, you're hungry, you're infuriated, you're full amygdala, and everything is like charged up, and you're like, bah! The baby crying. And then and you're like in full force, like upset and dysregulated, right? And then the mother comes, or the caregiver comes, you're given a bottle, breast, whatever, and you're fed, you're satiated, you're happy, and then there's this happy moment and connection. Now you're happy. Now the child looks at the object. Now she defined the object as the breast, but yeah, the mother, the object of affection, which then is, translated to all our relationships with everyone, or at least people who matter. But so this positive endowment, right, is given to the mother, like, this is the good mother. And then sometimes there's a time when the mother won't respond or won't come right away or can't come by or whatever. And then that's the image or object is the bad mother or the bad breast or whatever. And what happens is by about age 3 or 4, the child starts to look at the good and the bad in one integrated person. Like, oh, mother can be good and bad. She's not all good or all bad. But somewhere in that attachment, what happens if there's a break in attachment, there's all those the 4 types of attachment. Well, 4 types, but 1 secure attachment and 3 forms of insecure attachment, right? The avoidant, the anxious, and the ambivalent, those ones. And he kind of goes into that bit, more indirect way, but later on. But so with that sort of view of attachment, what happens in somebody with borderline personality disorder, or I mean, frankly, with any sort of attachment trauma, if you think about it, is that sense of identity diffusion is split. And he goes into sort of that definition when in his lecture, he went into the what splitting is. Splitting is that bad mother, good mother, all bad, all good. And somehow that split is not healed, integrated, etc. And that's what leads to this sort of behavior and response and way of going about in the world. So in that sense, he says, so there's, and again, in this one, in difficulty reading others, I made some notes about that one because that was very interesting. Because I had a question about it because I was thinking, oh, well, what about like in Asperger's or, that kind of like difficulty reading people? But it was a little different. It was a sense of like reading people in the sense of, oh, this person, it's not like they hate me. They're preoccupied right now. They are doing something else, or, they have something else going on. And not everything is sort of in relation to me. Like if you're not smiling, it's not because you hate me and you don't want to be my friend anymore. It's just that maybe you've got a lot on your mind, and that thing about difficulty reading others and reading self, because the self is regarded so much as a reflection of the other. Because that if you think about it again in that context of the baby thing, right? It's like, if a baby is walking and then they trip and fall and the mother goes, then the baby will cry. If the mom goes like, oh, you're fine, then the baby doesn't cry. It's like that occurrence is still happening into adulthood, where it's like the person is constantly looking for that mom to say, it's okay, or, oh no, you're in danger. Like there's always that looking outside kind of thing. So, and it kind of bleeds into the sense of emptiness, the lack of continuity in time. This is where he said sort of, even he said the thing about the sort of a little bit too much in the here and now, like, oh, right, we were together yesterday, we don't have to be together all the time. One second, okay. There, let me just take mute for a second. Way too much noise in my house. Can you hear any of it?
Oh yeah, yeah, you're doing great.
Okay. No,
You should be. No, I can't hear the background noise. Okay. No, I can't hear. Yeah.
Thank goodness. Oh, yeah. They're, corralling the cats to go out. Yeah. So, yeah. So,
So you're on sense of emptiness and lack of continuity in time.
Thank you. Speaking of lack of continuity. Because yeah, so it's a feeling of very much, a bit too much in the here and now, where a person is very like, okay, so say we're having a disagreement right now. The lack of, I almost think of it as perspective taking, ability, like in the Piagetian theory. It's almost, is it Piaget? I'm not sure, but it's a lack of like almost perspective taking, that, oh, right, we are disagreeing about this, but we are actually friends. Like, we have some longer standing bonds between us, kind of thing. It's just a like, oh, she hates me now, we're not friends anymore. It's that kind of sense of that lack of continuity in time. And the primitive defenses, especially projecting negative aspects of self to try to avoid anxiety. Oh, he went into quite a bit about this. What did he say? Because I was writing notes, and this is why I don't write notes, because when I'm writing notes, I'm not, my brain is not, because my brain remembers what it listens, and when I'm writing, I'm not actually listening, and then it skips over those. But he said something very interesting in this. The primitive defenses. Because yeah, he spoke about how, like, it's a sense of like, I'm feeling upset, therefore you must be upset with me.
I remember that.
Yeah. And that kind of projection. And one thing that Melanie Klein said in terms of that, or why that happens, is because it's like, I mean, if you think about it again, back to infancy, oh, it must be my fault that, because as a baby, you don't think like, oh, my mom's busy. It's like, oh, it's my fault. That's why. And that's kind of that what they say about like babies being very narcissistic in the, in the not pathological, non-clinical way of the word. But yeah. And over here,
Rochelle, you went on mute.
Oh, sorry. Thank you. I forgot that I'm scrolling down the slides, and so I clicked and then it made it go mute.
Did you talk about, hold on, go back one slide. Did he talk about variable reality testing?
We did talk about variable reality testing. Yeah, I believe it was the bit about being seen as like, okay, was this when he brought up the example of like, oh, if I'm walking here and then so and so turns around as soon as they saw me, well, maybe they forgot something in the car and they left and went back to get it.
So he just assumed it was about that,
but yeah, but it's variable reality testing, because it's like, wait, is that accurate or not? But that's what he went into with this bit. Well, that was one example, but then he gave some really good ones on this. The lack of integrated identity. This was okay. So the all or nothing sexuality, he spoke about that in the so the intense affect, the difficulty with sexual functioning, as in all or nothing, because it's like, either you're involved, you're too involved, you're in love and it's true love and magical, or it's like nothing because it's too painful in a way to engage that deeply almost. It's sort of like that was at least the sense I got in terms of the sexual functioning one over there. And then he spoke about the difficulty with regard to commitments in love and work, because there's this all or nothing element of if either you're a rock star or you're nothing, or you're this, you're that, and as soon as like there's a criticism or like a developmental area brought up, then it's like, oh no, we're not going there, it's over, it's over, that kind of a thing. Self-destructive actions, he did not talk about but he didn't talk about this in no, he did. He spoke about, I don't know if he specifically called out cutting behaviors. He may have used something, I think he used milder language, like I think he used self-harm, but he used milder words, but basically like he spoke about how sort of he inferred how the cutting thing is like how it helps in terms of like, oh, it's a physical manifestation of the emotional pain, and so that's that. It's almost like a person with BPD needs to feel those physical pain things so that they can in some ways like make the psychological pain
real, make it
release.
real.
Yeah, so that there's like something actual. Actually on that same note, this is not what Professor Bohart said in class, but there's a really good book called The General Theory of Love, and it's written by 3 MDs. It's a pain of a book to read. But there's one cool thing in that book that I learned, that apparently that cutting activity, or any painful activity actually, even like hitting a rubber band or whatever, it releases endorphins. It releases endorphins or whatever, the pain numbing agents in the body. It releases that. And I thought that was fascinating, because in some way, it's almost like a person with BPD is trying to self-soothe in the only way they know how. Because if you create pain, then your physiological body will emit the pain release, pain relief, what is it, like the analgesics. And that, so yeah, I just find it fascinating that it's like in whatever destructive way, all they're really trying to do is help themselves heal. So, yeah. Wait, do you have any questions on any of this bit?
Yeah. As you're talking about, I'm remembering him talking about this stuff. So you're doing a great job.
Okay, good.
I don't remember anything about moral rigidity and all that kind of stuff.
Moral rigidity. Oh, he brought up something that he brought up something with regard to like this was interesting. So, and I've heard this is not a new idea, that it's a controversial idea, but it's not a new idea. I have heard other psychologists say this, where it's almost like BPD is like a female version of APD, antisocial personality disorder, because of the way men in our culture can behave, and their outlets go off in pathology as antisocial, and then the feminine ones that are feminine, or like female gender role wise, they are approved or they're okay to do, and those pathologies get labeled borderline. So he spoke over here about, he kind of did a detour and went into like APD territory, antisocial personality, and about that that either like, you know, I must do this and it has to be like this or not, and like it's almost like on a diet, like a go for broke type of behavior. And yeah, so in that sense, it's kind of very black and white sort of. Again, it's that black and white extreme thing.
All or nothing,
yeah. And which is actually now making me wonder if CBT could be used for this. But I'm not sure, because it would not address the, you know, the psychodynamic fundamental, like childhood trauma kind of things, or like substructure things. So, but it's worth a try. Oh, okay. So I wrote the notes somewhere wrong, but here, the goals and objectives of transference-focused psychotherapy for borderline personality disorder is, in phase 1, the containment of self-destructive behaviors. So, for example, in dialectic behavior therapy, I think it's in distress tolerance or in emotional regulation modules, there are some exercises that you give a client to do, like for you know, for that week, and then they come back and report how it went. And in that, in one of those activities in there is like for people who will cut themselves, they suggest alternative activities, like putting a rubber band on and snapping it. Like, yeah, I don't know how it would replicate. I mean, it would pull the hair, which would be like, ouch. But anyways, it's, you know, it's a better substitute and a little less damaging. So you try to do kind of damage control in phase 1, and then phase 2 is the resolution of that, and through fostering the reflection on mental states of self and others, because that's where, like, you know, this is where he said, you don't say to the client, you know, oh, you're seeing me as this, or, you know, you're reenacting your drama with your parent onto me right now. No, you try to encourage self-reflection by saying something like, oh, right now you're seeing me as the persecutor, or, you know, whatever it is, like in that moment. And you encourage that reflective mental state and that reflective skill. So oh yeah, this was the person. I wrote some notes. Person views everything as a dyad, relating to self as the dyad. If a person is nice to me, then I am good. But the quote unquote normal is integrated organization to see people and ourselves as both good and bad, right? So again, here it's like again, and this affect thing, he said something here about how the affect determines how things are seen, you know, and it's very much seen in relation with the affect, which, because it's so labile, is like highly, you know, dangerous, sometimes unstable for yourself, because, you know, who wants to be in that kind of a storm, right, all the time? But then to see yourself as a reflection of how somebody else sees you and how they're treating you, it's like very much putting your power in other people's hands in a way. Dyads as the building block. So the individual identifies with the entire relationship dyad, not just with the self-representation or object representation. The dyad exists within the individual. Here he said, Basically it's like a thing of, so if I am angry with myself, I'm going to create a scenario where you get angry with me, and then you start acting like that. And then my belief that I suck is, and my own like self-hatred or anger towards myself is kind of now being actualized, so to speak, from you. And so I'm this bit about like how it impact its basic impact is on how the individual relates to him or herself, although it regularly gets played out between self or others. That's why he said it's like, it's almost like if a person with borderline personality disorder creates a situation where the other person is angry with them and they're like perceiving it that way and like internalizing it that way, what's actually going on is that the person is actually angry with themselves for something. But that because of that like age 3-4 thing of like, you know, that reflective ability of like, oh right, I'm pissed because I did this stupid thing, like, but whatever, I'm human, you know, that ability is what needs to be developed, because that's what's missing, or that's where like the developmental area is. And in that sense, sort of the individual identifies with the entire dyad, you know, like you're persecuting me, I actually want to persecute myself, I'm pissed at myself, but I can't take a step back and think about that, rather than, so I have to say that you're the one who's doing this. Which then he brought into, he said something about like that reenactment, like of say an abusive parent. But he said, but if you think about it, that may have actually been the truth in their case. But it's kind of, again, like in my mind, the way I look at this is like, it's all repetition compulsion, right? You're recreating the same, you're trying to do a repeat Groundhog's Day to fix it. So I honestly, I think this stuff is incredibly hopeful, because it's like, you know, because it's like in all your pathology, you're trying to heal yourself. That's what you're actually doing. You know, I think that's what the core message of it all is, because it's like, wow, how cool is that? Like, even when people are like doing really bad shit, they're actually just trying to recreate and repair and, you know, make it better. They're trying to fix something. They're trying to fix an unfixable situation from way, way back. But the great thing is they're still trying to fix it somehow, in some, you know, way that is not computing properly to anybody else, but, or not even working for themselves for that matter. But that's what they're actually trying to do. And that brings me so much hope, and I get so jazzed by that. So dyads of similar, what did he said something here too that was interesting. Was it, what did I wrote something there? Patient's internal world? No. Oh yeah, okay. So here, what did he say? Sorry. Like I have to go tape recorder back. Like my chip. What did he say? What did he say? I think over here, this last bullet point, the dyads of similar affective charge aggregate together in the mind. I think this is where he spoke about, it might be wrong, he may have said it later on, but he said something about like how the like the, yeah, the persecutor and the, you know, the oppressed, but then the other one was like the child and the all-giving parent, or like, you know, these different like almost archetypal roles. And those things, those patterns kind of go and sit together in like, you know, in like aggregate buckets, you know. So yeah, I don't know if that helped at all. Oh yeah, okay.
He said some
So like
stuff
this.
here. I remember this one.
Yes, yes. Over here, yeah. So this is where he says like, okay, so like if the object, right? So the other person is the if that interaction is going negatively, then their schema, their
And
own
they'll
self
have
is
negative self,
negative,
and if it's going
right?
positively,
Positively, then yeah,
they'll be positive.
right. But
Right.
that's where sort of that split is, because
Right.
you see that it's that good breast, bad breast business that's going on here. But now in, oh yeah, okay, so here, so but in normal, that's a thing, in integrated organization, it's complex, it's more nuanced, and that's our goal of therapy. And he also said that, he said, oh, I remember this because I thought it was pretty cool. He said, and that's actually the goal of good parenting or a good childhood. But if that doesn't happen, then that's what the goal of good therapy is, that integration of like, yeah, so it's sometimes good, sometimes bad. This happens. I'm neither a good cop nor a bad cop, John. Like yourself, I'm a complex amalgam of positive and negative personality traits that emerge or not, depending on the circumstance. Yeah. Oh yeah. Okay. So at this point, he said, "Oh, forget about this because this is not relevant for the exam, etc." But and it's from Melanie Klein's theory. But I think it's super cool because I'm very interested in schizophrenia. Side topic, but this whole bit about the the split organization, the different types, the paranoid schizoid type, the depressive position, yeah, I thought that's all cool. Though I think it's cool because it relates to sort of the it relates to sort of those 4 attachment types. But then this one specifically, okay, from that paranoid schizoid to the integrated organization depressive position. And this, I don't know if you read this book, but Alice Miller.
The gifted, isn't it the gifted child?
Yes, the drama of the gifted child.
Yeah.
In 212 we had to read that, right? Oh my goodness.
I haven't taken 212 yet.
Okay, you totally should. If you do, take it with Professor Otto, Stephen Otto.
Really, I heard
he's amazing. Yeah,
really?
or Dr. Quatman. Yeah.
See, I've been waiting for Dr. Quatman, and she doesn't seem like she's not teaching it anymore. Every time I think, okay, I'll get it this quarter, she's not teaching it.
Oh man, yeah. But take Professor Otto also. Professor Otto is absolutely brilliant. Yeah, he used to be a lawyer before he changed careers.
Yeah, I heard that.
Yeah. He's awesome. And but I took that class with him, and I read this book, and we only had to read like a part of it, not the whole thing, but it was so awesome. I had to read the whole thing. Plus, it was on Audible, so I could just listen to it and like walk my dog and stuff. So it was, it was totally fine. But this is why this sentence is like just wow. So remember what I said, like how people are like just keep trying to heal, right? And while they're trying to, but the problem is that they're trying to heal by repeating the same bullshit again and again. But the problem is, and this is a point that Alice Miller makes in that book, the problem is that you cannot fix that situation that already happened. It already happened. You're already done. You need to grieve it. It'll never come back. Like you can try to make people your parents and whatnot, in the everyday life, but what you lost is already lost. Grieve it. Not even deal with it or get over it. No, grieve it. And that is why this word, the depressive position, is so crucial to this integrated organization, because it's like only when you get it that, oh, right, that's not coming back ever. Doesn't matter who I repeat this drama with, right? That's it. Then but the problem is most people don't want to go there because it's painful. And you're afraid that, oh, if I go there, how badly will I break? How hard will this be? Will I have a breakdown that I cannot get over, that I cannot get up from, right? So you keep doing the same thing over and over again. But the interesting thing is that if you actually go there and go like, yeah, it's gone. Oh my God. And you go ahead and grieve that, right? And that's, Alice Miller's book is hard to read. Like, it's like emotionally hard book to read, like if you internalizing it while you're reading it. But she totally gets into that whole thing, and as does Melanie Klein, about the depressive position being actually the start of integration. And actually, there's a very funny TED talk as an aside that I'll send to you later too. It's by this guy, Alain de Botton. And he says like the goal of all, the goal of philosophy is like sadness. Like if we can get from like, this thing from like hope to just plain sadness, like I've done my job. And it's so funny. I'll send it to you.
Okay.
So how is this accomplished by, so then he didn't say anything further about this bit, but okay, so the patient's internal world. Yeah. Okay, here I wrote something. So so this is where it's kind of, the self-representation, the object representation, but it's basically like if S is for the subject and O is the object, so the S is the patient and O is the people in their life. So if they're seeing themselves as like, or they want to enact, or not want to, but they're enacting the weak, mistreated figure, and then the person on the other side is the harsh authority figure, the affect there that's happening is fear, right? So, and then, so the way to think about it is this: if the internal affect that's going on in the patients, in the clients here and now is fear, then they're going to present and create that dynamic of your harsh authority figure, I'm weak, mistreated figure, in order to give space to that feeling of fear. Because that perspective taking ability of saying, I am terrified right now, and just sitting with that is absent. So instead of, because it's absent. So because you can't do it in yourself, you have to create that dyad and then be afraid of this harsh authority figure. And then same, if the feeling inside is, I'm feeling very loving, then the whole childish dependent kind of persona is out, and viewing the other person as this idealized figure, right? Then if there's anger, it's like, oh, I'm going to create this thing where I'm powerful controlling figure, and like, I'll make a phone call and like bitch out the person on the like some customer service person or whatever, because like, I need to get that rap need met, rather than just saying, oh, I am so furious right now, and just being with that. So that's kind of where this transference-focused therapy comes in, because, and this, I'm going a little bit by what Professor or Dr. Kernberg, Otto Greenberg says in one of the YouTube lectures I saw. But, or maybe, no, sorry, it was what Dr. Bohart said. So I forget who said what. No, Dr. Bohart said this. It's like, if they're treating you as a patient, as a therapist, as a harsh authority figure, when you're not being harsh and authoritarian, you're empathizing, you're there with them, you're holding space, then you as a therapist need to know that that's like the emotion that's going on inside them right now is fear, and help them gently to guide them to that realization, because that perspective taking ability is not there in themselves to go like, oh, I'm feeling fear, That's why I'm making you out to be like, something actually that you're not. So yeah, I thought that was brilliant that he called it out like that. Oh yeah, and then the experience of the self and of the therapist. Oh yeah, okay. So this is sort of more to the point of what I was just saying about the power of the internal world over the external reality. So like, I'll just go there. Okay, so suppose right now in this moment, right? What am I feeling? Nothing. Maybe tired-ish, kind of, because it's been a long day. But instead of saying, oh, I'm feeling a little tired, it's been a long day, say, oh, she doesn't look interested in me, I think she's getting bored, we should end this session. You see? It's how the experience of the self is like that power of the internal world over external reality. Then I'll start being boring so that you'll actually like yawn or something, and then it'll reinforce and be like, see, she is bored with what I'm saying, I suck. And that kind of narrative perpetuates, kind of thing. It's so freaking fascinating. And then, and he spoke about this, but he also spoke about it, Otto Kernberg also spoke about it in the YouTube video, where those things, those images of like victim, persecutor, those roles, they switch quite quickly, and that that's why the oscillation occurs, but again, not in consciousness. So the person is not like very self-reflective and aware that, oh, I just did this, but it comes out in the behavior. And you as a therapist, if you're doing transference-focused psychotherapy, your job is to interpret that, and interpret not by stating explicitly, but keeping the interpretations very proximal to what the patient can understand, not making too big of a leap, because otherwise, what? No, that's not, and then a psychoanalyst will say the person's resistant, when that's not the case. It's just that like you took too far of a leap, the patient wasn't there yet, So that bit about like, oh, okay, I see that, now you're treating me this way. Oh, now I feel like I'm in this role, and I feel like I'm in this role now, just keeping it very like what I'm feeling versus, and like building that in the client. And that's why, kind of, because it takes so long, that you can see how it would take 2 sessions per week, right, to do something like this. And then and then this thing about like the one dyad against the other thing. Let's see, did I write anything on all of this? He said something about this that was pretty cool. He said this thing, it was so good what he said. It was something like if the client feels like too vulnerable to be in that dependent child gratifier and provider type of dyad, they will make it so that it's a different one, because they can't go there. So like they'll portray something opposite. But he said it much more articulately than I just did. But it was just brilliant. It was like it was a full-on defense. It was like a full-on defense move. But in, say, the context of like narcissistic personality disorder, where the defense is more egotistical type of defense, this defense is more of one where a person will create a sort of drama that'll piss off the other person, that will like destroy it, so that there's no question of like the longing love thing, but now it's the fear, suspicion, hate. So rather than being like, or like an avoidant personality, which like, no, I'm fine, I don't need anything, I'm good, you know, or like, because all these personality disorders, right? They're basically just different ways to attend to ourselves, right? So like someone avoidant may be like, no, I'm cool, I'm just busy. And a narcissist, I don't know, what did a narcissist say? I have to do my hair or something, I don't know. But this one will create the thing that will like get the other person to get upset with them in some way, and then their own thing is reinforced. Oh yeah, here he said, okay, he spoke quite a bit about this one. He said that so the strategies are, you know, the long-term goals and the integration primarily. The tactics are so this just basically, he's just defining the verbiage of the method and the vocabulary of the method. Like tactics sounds so bad, like, but that's just what they call it in the manual. And the technique is the consistent intervention, like one of them being that he went into great depth about was interpretation is one technique. But those are the consistent interventions that address what happens from moment to moment. Like, oh, now I notice that I'm feeling, when you just blamed me for this, I felt this. Or, oh, when you said this to me, I felt like you were, not I felt like you were putting me in this role, but I felt like I was in this role. How was that feeling for you? And that kind of thing, moment to moment again. Again, interpretation is attuned to the here and now experience of the patient. And interpretation depends strongly on what is not on the surface, but what is not on the surface in the moment, but what is known from other moments or from nonverbal communication or countertransference. And this bit I thought was so cool. The fact that it's the takes the patient one step beyond his or her current level of awareness. It's so important to keep it proximal, he said, like not to make too much of a leap, so that you're building that little insight, you know, rather than like just dumping the whole jug of emotion water onto them, like just drip by drip, because otherwise it's just too much. And then, you know, you have a client who's super flooded, who can't cope with you because now you've like revealed everything and you're horrible, because now like they were not ready to grieve it and you just crashed their, you know, their canister of however they were holding it. So it's that's why that proximal steps are very important. Yeah. And he said, I think he said it twice, this is very important. That's why I was like, I remembered that, like I made sure that was salient. Steps of interpretation. Oh yeah. So again, here he went into like the task, and I think our readings went into it, the mentalization part in the chapter, and elaborating the understanding again, like kind of what I just said about, you know, elaborating it slowly, building it slowly. And oh yeah, and this was also very important, considering that so getting the client to realize that the therapist's experience of the moment may be different from the patient's experience, because, and he I think this was verbatim, he said that like getting them to realize that the way they would have reacted. So suppose you as a therapist say, oh, I felt a little slighted by what you just said. And then the person goes, oh, you felt slighted by what I just said. What did I just say? Now suddenly, like, they were in the persecutor mode, right? Dishing it out to you. And now they have to sort of pause, and then the natural response is going to be for them to go into the victim mode, because if I'm not a persecutor, I'm a victim, right? So they go into the victim mode, and they're like, oh, no, you know, and say, no, I felt slighted by this, like you know, like I'm not getting you on this and that and that. And then they go, oh, that's a very different way of reacting than how I would have reacted had I felt like on the attack. So building that slowly and getting that perspective taking, that, oh, I wouldn't have just gone and blown up the whole place, you know, or I would have gone and blown up the whole place. But this person is saying that, oh, I just, like, let's take a step back, I need to breathe through it. It's like, oh, okay, there's some people do other things too. Okay, cool, you know. So building that sort of thing. And then if necessary, offer patient a version, what I just said, offer the patient a version of how the therapist is experiencing the moment, in a way to sort of what Professor Otto talks about or spoke about was like this corrective relational experience, like where you're providing the client with a different possibility of how, you know, how someone would react to them. If they never had boundaries before, this is how boundaries look. If they never had that unconditional caring and acceptance, well, this is what it looks like. So presenting that as a corrective relational experience is sort of how it's in some ways it's like psychoeducation, but it's also like that therapeutic healing, you know. And contrast the immediate experience of the self and of the therapist with that seen through other channels or at other times. Oh, yeah. So like, here he said something about like, so say the therapist or the client is upset with you that, oh, you know, you took that person's phone call just now, therefore, like mid-session. And so they're a little bit like, you know, distant, or like they've like closed off or something. Remind them, well, yes. So right now you know, you're feeling like I just abandoned you when I went and took that phone call. But let's remember how many times, you know, how many sessions have we had? How many times have I actually stepped away? How many times have I, you know, actually abandoned you in that way? And, you know, and is it like, not, is it truly abandonment? Because that's like, you know, questioning their judgment, but, or like, what is it? Diminishing or like neutralizing what they said. So not that way, but more like reminding them of the other times, because then in the external world, that kind of builds that skill of, oh yeah, this person was walking down the hallway, saw me and turned around and went, but that was today. Maybe they did leave something in their car or whatever, you know, but there are other days when they didn't do that. There was this day when they actually helped me, or there was all this other sort of, like, I think in CBT it's called, what is that, different, in CBT it's called what, like evidence, like different evidence, right? Evidence to support and evidence that contradicts. But yeah, consider the reason for the splits and put the above in context of other relations, right? Like in terms of like, you know, with like their significant others, or with their colleagues, or in other scenarios of their work, or other scenarios of their life. Try to help them to see those in those other contexts too. Like, oh, where else, you know, where else do you feel like that? If somebody like takes a phone call while you're in the meeting, you know, how else does it show up, so to speak? Oh, and then, oh yeah, this one. But consider the reason for the splits were, he said something about recognizing that it may be like it's a defense mechanism. It's too traumatic to go there. And that's the reason why. When there is oscillation in the dyad, elaborating the second level of, yeah, okay. So this is sort of similar to, you experience me as cruel, and okay, so like yeah, I think for this one, I remember just him saying all these words. So I think he just read this slide, like again, engaging in that interpretive process. You see yourself as a victim of my cruelty. You experience me as cruel and uncaring. If you see me this way, it would make sense. However, is there evidence that things could be otherwise, that you may be acting cruel and attacking? Is it hard to see and accept that in yourself? We agree on the affect, but not on its source. Yeah, and then if you, yeah, I think for this one, he just like said the same words. Yeah, again, the interpretation and framing that interpretation for the client as, okay, so, oh, this one actually illustrates that one, that slide back here. This one, this verbiage does a good job of displaying that. So you feel positive, but you're like, positive, too much love, too much love, too much love. I cannot take this. I cannot take this. I have to destroy, must destroy now, and create a bad situation, where, you know, like turn it, quickly turn it, so that like as a like a self-protection defensive reaction, but making that kind of more, you know, interpreting that for the client. It's almost, in a way, I feel like it's almost like not rehab, but, you know, like the physical rehab, like if you have a stroke, or you, like, you know, you, like if your arm is in a cast or something, and then your hand can't move, and then you've been taught how to move that hand again. It's almost like that, but for your emotions, is how this TF what transference-focused. I have trouble with all the letters, alphabets. Beyond symptom change, increased integration and differentiation of sense of self for others. Okay, I guess here is this. I don't remember him saying much about this.
I think he just read this one. I don't think there was
Okay.
much to this one.
Yeah, because like what all happens, you know, the results, or the outcomes. And yeah, I don't remember him saying anything about this, except for I think in the beginning, where the whole class spoke about, like, you know, the value of case history versus randomized controlled trials. Because if it's randomized and if it's controlled, then it's sometimes so controlled that it misses out all the cool details that you can get in a case history. So yeah, but he didn't go much into this. And yeah, and then he made us go off into the groups. Yeah. That practice was intense, man.
Oh, is that the one where you worked with Corey?
God, yeah. Yeah, that was something. But wait, I had something. Oh yeah, this is Marsha Linehan.
She's a character.
Yeah, I haven't.
I watched something on the Division 12, and
yeah, I'm gonna stop.
She has a mouth like a sailor.
Oh, hold on, what's going on?
No, that was me.
Okay. Yeah. Oh, I don't know. I know about her method, and then sometimes I'll save videos like that in my YouTube queue to watch later. And then sometimes I get around to it, sometimes I don't. But
Wait, say that again. Say it one more time.
I said, no, I'm not very familiar with her stuff, but
Mhm.
I heard of her and I saw like that was like a cool video. So I think it was her. So it was herself. So I saved it in my YouTube queue to watch later. And sometimes I get around to it, sometimes I
Oh,
don't.
I see.
But
Yeah.
yeah, but anytime I find something like that's by the original person, I'll like try to save it. Like Carl Jung, my goodness. If you listen to any of his stuff that old rare recordings of him speaking, oh my goodness, he's brilliant. Absolutely brilliant. Yeah.
No, I was trying to decide if I wanted to do DBT, and I saw this video of
The
Marcia
class?
no, it was on YouTube, and it was on Division 12, the website where we're supposed to go look for what we wanted to do.
Yeah. Oh, wait, I'll
And
stop recording, by the way. Sorry to interrupt you.